Well, hey everyone, welcome back to Pushing the Limits. Today, I am super excited to have a very good friend, Dr. Greg Brown, to guest. Dr. Greg, welcome to the show. It's fabulous to have you.
Thank you, Lisa. Really lovely to talk with you this morning.
I had the wonderful privilege of going down to your clinic last week and having a beautiful barbecue with your lovely family, having a wonderful meal with everybody there, and with your business partner, Mike Winton. So that was absolutely fabulous. So thanks for hosting me. You guys have Wellington Hyperbarics, and today's episode is going to be, well, we're going to cover a couple of different topics because Dr. Greg has a very interesting background. But we'll be focusing largely on hyperbaric oxygen therapy and diving into the weeds there. But before we do that, Greg, can you tell us a little bit about your background, where you come from, your specialties, what you do?
Okay. Yep. So as astute listeners and viewers may pick up, I'm not a Kiwi. Well, I am now, but not by birth. So I originate from the UK and trained as a doctor in Sheffield, in Yorkshire, which is a great place to train because the people are really lovely. So I finished up there in 2005, did all my junior hospital rotations and eventually trained in general practice in that area, and then came to New Zealand ostensibly for about 16 months, 11 and a bit years ago. So general practice is my background. I then took a turn into left field by joining the New Zealand military, where I spent the best part of a decade in and out of uniform, and the Navy was my service because I don't enjoy shaving, sleeping in holes, or running too far. I'm sorry to say, Lisa, talking to you. And then subsequent to leaving the Defence Force, I've got involved in hyperbaric medicine and in really trying to break the mold in this country.
Yeah, and you're really at the forefront. What you and Mike are doing is just, revolutionizing. I've been banging on about hyperbaric oxygen therapy for 8 years. I haven't really made much of a dent in the universe yet, but it's a super powerful. I credit hyperbaric oxygen therapy with saving my mum twice, both, certainly in the aneurysm and stroke that she suffered 7.5 years ago. It was absolutely pivotal in the rehabilitation of her brain. And since with the cancer that we've been dealing with, it's been an adjunct therapy. It's not a cure for cancer, it's an adjunct therapy that can be beneficial. And I certainly think it's had a big role to play in the fact that she's still alive when she was meant to be dead a long time ago. And I'm very, very passionate about it. I've got a clinic. That's why I came down to see Dr. Greg, because he's going to help me with my clients. But you guys have got the Rolls Royce of hyperbaric chambers. I don't quite have the Rolls Royce. I've got a single hard shell chamber and a soft shell chamber, the soft shell you see in the background. But you guys have got the real granddaddy of them all. You've got a couple, actually. Tell us about the chambers.
Yeah, I mean, I would say it's more a Lexus than a Rolls Royce. I mean, the Rolls Royce need to be seen to be believed. They exist in places like Dubai, where there's an awful lot more money sloshing around than there is in little old New Zealand. But yes, we have chambers made by a company called OxyHelp, and this is a company that does its manufacturing in Europe, and really it's almost the iPhone of hyperbaric chambers.
Yep.
I think what perhaps goes unrecognized or under-recognized is that the technology has moved on really quite a lot in the last 10 years or so. And what you get with something like what we have is a very large degree of automation on the technical side of things. So the way that it manages the pressure, the way that it increases and decreases safely, the controls that you've got inside or outside the chamber, it really is next level, as well as being extremely comfortable, very spacious, and quite a pleasant place to be.
Yeah, it is absolutely, and your chamber, of course, goes up to, or does it go up to 2.4? Is that correct? Or 2?
It goes to 2.0. Yeah.
2.0.
So we don't go beyond that.
Yeah. And so, and my one for listeners is at 1.5 atmospheres. I would love to have one that goes up to 2, but we are talking a heck of a lot bigger investment. And the 1.5 can be very effective in certain things. I would like to have a bit more pressure for other ailments, but sometimes it's a case of get the best you can get. And it's certainly going to be, sort of massively beneficial, even at 1.5. 2 has got, certainly for things like diabetic wounds or crush injuries or after surgeries or even with cancer, it would be better to be at the 2 if you can get access. And Greg and Mike have, you've got your clinic in Wellington, but you've got some sister clinics in Palmerston North and Nelson.
That's
and
right.
I've got my one in New Plymouth. There are other ones popping up around the country. Shout out to my colleague who is opening in Pukekohe shortly, Dr. Dean Carter, who managed to get his hyperbaric technician's certification with Dr. Jason Sonners last week as well. So fantastic to have him now qualified in that. And it's exciting. It's an exciting time for hyperbaric. People are starting to hear the word bandied around, and occasionally people will know that that's the thing that the divers have, isn't it, when they get the bends. Can you just briefly go over what is hyperbaric, and then we'll dive into the benefits of it?
Absolutely. Everybody's minds go to dive medicine if they've heard of hyperbaric oxygen therapy at all. And of course, it is the same modality, it's the same principles, but the application of those principles is much broader than generally goes recognized. Very, very simply, it's a dual drug therapy that involves delivering high flow supplemental oxygen at pressures higher than atmospheric pressure. And that's really it. It's certainly better, I would suggest, delivered in a hard shell chamber from the perspective of the pressures that you can achieve. But the reality is that it depends on the indication, which sort of pressure you want to treat at, and there's certainly benefit in both sorts of approaches, hard or soft shell. But we've chosen to go the hard shell route because we think that, especially under medical supervision at those higher pressures, we can treat a broader range.
Yep.
In terms of how it works, there is the upfront effect of direct oxygenation. You do dissolve a very, very large amount of oxygen. It doesn't just saturate hemoglobin, that can happen very, very quickly. It also puts oxygen directly into the blood plasma, and that's just a function of the way the gas laws operate. But in the longer term, and the way that it's delivered these days, there are other effects around growing new blood vessels and increasing the amount of circulating stem cells, and actually also epigenetic changes that are now apparent and continuing to be researched. And and the exact mechanisms are very, very complex, and to an extent they're above my pay grade. But in terms of being able to deliver this safely, the research base is considerable. It's impressive. And it just keeps getting bigger.
Yeah, exactly. All around the world, studies are being conducted all the time. I mean, I know Israel is one of the leading countries in this, as well as America. We've got some great doctors like Dr. Harch and Dr. Jason Sonners, who's been on the show, and Dr. Scott Scher, and many others. And so it's hyper oxygenating the body. It's getting the oxygen into the plasma, as you said. When that is the case, then it can actually get through, because also the oxygen molecules themselves have been compressed like a can of Coke with the gas in it, right? It's got, the carbon dioxide or monoxide, whatever it is, and you open it up and it bubbles out, right? And that's the gas expanding. So that's actually what's happening. It's compressing it down, and then it can permeate through damaged tissue, hypoxic tissue, inflammation, where there's inflammation. And these are areas of the body that can be very hypoxic, meaning low in oxygen. I say after surgery, if you've got a swollen joint, if you've, twisted your ankle. In the case of cancer, there's more oxygen around the tumors. Cancer does not like oxygen. The blood-brain barrier can get through the blood-brain barrier and rejuvenate neurons that are quiescent, that aren't working properly. Can't do anything about the dead ones. Sometimes when you've had a stroke or a brain injury, there's dead tissue that's dead. However, it can help with the rewiring, and it can help regenerate these neurons that are not quite doing their job properly. Is that an accurate assessment?
Yeah,
or did I get anything wrong?
All of the above. Yeah. I think you've raised an important distinction there between tissue that's necrotic, that's completely dead and is unsalvageable by anything, including hyperbarics, and tissue that's under oxygenated, that is metabolically dysregulated, it's unhealthy, it's unhappy, and you would find that around the area of an infarct in the case of a stroke. So you've got your dead bit of tissue, you've then got what's referred to as the ischemic penumbra. So ischemic meaning obviously lower blood flow, less blood flow than it needs. And it's that area that you can get oxygen into and rejuvenate. Unfortunately, as I say, the infarct is the infarct. That's gone. But the brain is an incredible thing. Obviously, the younger somebody is, the greater the degree of neuroplasticity. But it is capable of making new connections and solving problems. Yeah, absolutely. Rewiring itself. Yeah. Given the right conditions. And I mean, what hyperbarics is doing is it's essentially attempting to signal to the body, hey, look, there's a problem here, go and fix it, as much as anything else. And then the body, being a wonderful thing, does its thing.
Yeah, and it's the great thing with just hyperoxygenating is you're not introducing a toxic substance, a drug or anything into the mix. It's actually using the body's own mechanisms, the increase in stem cell production, the decrease in inflammation, the angiogenesis, the creating of new capillaries and things that can actually help reroute things, and that thing like getting through the blood-brain barrier is quite problematic. So getting the oxygen to damaged stroke or concussion or TBI, and these can be, obviously, if you've just had a TBI or a concussion or a stroke and you can get into a hyperbaric straight away, then all the better. But it's not that it's too late for people who have had these things years ago. It can also be beneficial. And Mum, when she had her, she was 74 years old at the time, and now 80 when she got cancer. Her brain and neuroplasticity, I've lived this. I've lived somebody losing their brain almost completely, being not much over vegetative state, to coming back to a person who can drive a car, function fully in society, to then going back again after the brain tumors, to being a baby again, and to come back to being a near fully functioning. I'd say Mum's operating at about 85%. There's some deficits there for sure now. But she's still, sitting at a coffee table with Mum, you would not know she has anything, only when she goes to walk and things that she's a little bit more fragile and a little bit more unstable. But to see the brain go for it like this, complete damage, right back, complete damage, just absolutely phenomenal. And it gives me hope for people who are, definitely for younger people who are having brain injuries or early onset dementia or Alzheimer's or any of these things, that we need further studies. There's a hell of a lot of studies, however, that have been done in this area, and it's not really being recognized, as with all things in medicine. Hey, Greg.
Oh yeah, absolutely right. And your mum's story is absolutely incredible, and is unmatched really by anything that conventional medicine could offer or did offer in that scenario, right? Which, having read your book, is it was a fairly wild story of really just frustration at a sort of fatalism that's it. She's had this. This is how things are going to be. And we've seen people 10 years after significant traumatic brain injury, and seen unreal improvements. It's absolutely not too late. No. The degree of improvement and exactly what that's going to look like, I think that's that's the variable. That's the frustrating thing. You know, you look at what the Israelis and the Americans do using things like SPECT scanning, which is like a functional blood flow scan. Essentially, there's nothing that we can do here that matches that. And
no, we just don't have SPECT.
We don't have it, no, and nothing else is any good. You know, functional MRI is too inherently variable, just depending on what the person is thinking about on the day. Even, you know, it's not a substitute. So, unlike people who can get SPECT scans, we can't say, well, actually that bit of the brain's gone. I'm not going to improve your left arm, but I might improve your speech. Whereas the overseas people can do that. So we've got a ways to go there. Yeah. And I think, you know, part of the problem, you know, as we've said, is that you are switching on the body's healing and regenerative processes, right? You are doing so with something that essentially is non-pharmaceutical. I mean, oxygen, you know, is a prescribed drug, you know, so we prescribe it. I prescribe it for the patients under our clinic and in our satellite clinics under standing orders. But that's about it. You know, there's no, it doesn't fit the medical model. It's not, it's not getting any traction because it's seen as fringe, and it's been around for hundreds of years. As you've said, the evidence base is
huge,
highly compelling, and every single study that's ever done in its conclusions, pretty much, you know, one of its conclusions is, you know, needs more studies to be done.
That's just the standard bullshit answer.
Yeah, it is. And, you know, where do you draw the line on that? And I think as well, the part of the malaise, I guess, in evidence-based medicine, which has morphed into something that it was never intended to be. I mean, you know, potentially we could get into that. But part of the malaise is really this fixation on the randomized controlled trial as being the only way of assessing the efficacy of an intervention. Now, the only people really that have the money to do big randomized controlled trials that are actually, as well as being the gold standard, they're also the most manipulatable. But the only people who've got the ability to do that at the scale that you need to achieve the power to get the result that you're looking for is the drug companies.
Exactly.
You need very, very deep pockets. So when are we ever going to get the same evidence base? Probably never. So where do you draw the line and say, well, actually, we've got enough? And that's the position that we came to then put, you know, money where mouths are and to start doing this stuff.
Yeah, and you know, to set up what you guys have set up is next level expensive. This is not a get rich quick scheme, because I can tell you, it's like you've got to do the education, you've got to do and I've you know done that here too, to the degree that I'm able to do that to do that, because we're passionate about this, because I've seen it save Mum, and I've seen it save many of my clients and have incredible results. And I've read the studies, and I know that this is an impactful, amazing therapy. But we, like you said, there's no money behind it. There's no big dollars to be made in this area of science, and so it's not going to get the attention. And, you know, Jason Saunders has this beautiful analogy, who's also a hyperbaric expert, of talking about randomized controlled trials. If you had a plant that's stuck in a cupboard in toxic soil who hasn't had any water, and it's looking pretty grim, and you go, right, I'm going to change the one variable in this randomized controlled trial, and I'm going to change it, I'm going to give it water and see whether it survives, but it's still in the dark cupboard and it's still in the bad soil. And then you come to the conclusion that the water does nothing. It doesn't help. It's still a sick plant. And, you know, and it goes on the story of changing the soil but taking the water out. In other words, it's the synergy of all these things.
Yes, yeah, it's a good analogy, isn't it? Because, you know, if you ask the question, well, actually, where do we see plants thriving in the world, you know, and what conditions are present? You know, that's a really different question, and that's a different way of doing the study, isn't it?
Exactly. Yeah. Let's look at the elements of what makes a healthy person, and let's look at, you know, and this is why I love cellular health, like going right down, not even to a systems level, but down to a cellular level, and trying to help the cell be optimized, trying to optimize the mitochondria, because I do believe like the mitochondria are absolute key when it comes to optimal health. You know, if your mitochondria are sick, you're sick, and you're not going to have much energy to repair yourself, you know, so anything that works on that really sort of deep level, which hyperbaric oxygen does, this has got to be good. and anything that uses natural, the body's natural healing processes is just, but it's doing it on, I was going to say on steroids, it's probably the wrong analogy, doing it extra strong. I mean, if I just run through some of the things that, can improve brain tissue oxygenation, stimulate brain tissue regeneration, regrow nerve fibers. That's mind-blowing. Form new neural connections, regrow new blood vessels and improve blood flow, stimulating idle brain cells to function, speed recovery and rehabilitation time, stimulate tissue repair, increase levels of neutrophils and nitric oxide, reduces inflammation in the brain and body, stimulates upregulation of growth hormones, which we all know is anti-aging, reduces brain damage from swelling, improves cognition, thinking, and brain performance, new collagen, skin and tissues, reduces pain and swelling. I know this is getting boring, me reading this list, but I want you to sort of get the point. Regrows healthy tissue, skin and bones, heals ulcers, wounds and injuries, kills bacteria and infections, makes antibiotics more effective, stimulates angiogenesis and axonal regeneration, enhances mitochondrial function, promotes stem cell production by up to 800%, increases cerebral blood flow, decreases cerebral edema, reactivates quiescent neurons, and it's safe and comfortable and pain-free. Well, why the hell would you not do this?
Yeah, it's great, isn't it? And if I said all of that in a newspaper advert, the medical council would come down on me like a ton of bricks, even though it's true.
It's clinically provable.
Yeah.
And my listeners might have heard my story about my dad, who was, unfortunately died 2.5 years ago in terrible circumstances in the ICU. And I came with the clinical research for intravenous vitamin C in relation to sepsis and the reduction in mortality rates of 48% if you can get it early enough. And I was told, we're not interested in the clinical research. This is a legal matter. So my dad, my opinion, died because of a legal matter, because I couldn't get him what he needed at the time when he needed it. And so one of my dreams is to, as I've said to you, Greg, is to get the right to try law here, which is they have it in America in some states, where at the end of life, if your doctors have run out of options for you, you're allowed to try such things like that, anything that could be possibly helping within limits, obviously, of common sense.
Yeah, of course. And Paul Marek proved the efficacy in the ICU environments really beyond all reasonable doubt. And I'm not surprised, right? Because I've been working in medicine for 23 years, so I know what it's like. I know the sorts of conversations that take place. I know the sorts of personalities involved and the vested interests and often just the sheer blinkered arrogance, but it's actually still profoundly shocking to hear an experience like yours. And I don't know that there's an easy fix for that, because it is a cultural thing within medicine. And part of the problem, back in the day, if we go, so when I was a young doctor, or when I was a medical student, before all the grey hairs, the whole evidence-based medicine thing was coming in, and it was like, this is fantastic, right? Because what we used to do was eminence-based medicine. You had your eminent professor. My first job as a qualified doctor was for the professor of surgery in Sheffield. Great job. You got the professor. He knows his stuff. It's an apprenticeship model. You train under this person. You do what they do. You learn from them and their experience. You add your own experience to that, and you develop an approach that then works for you going into your career. And hopefully you keep learning and keep evolving in that sense. There were issues with that model, and certainly there is a huge place for doing decent scientific trials in medicine. But the way that then that evolved was for evidence-based medicine to become the new version of eminence-based medicine, just with more arrogance and a bigger brickbat to hit people with who didn't comply with what somebody on some guideline committee thinks is the right thing to do, right? Yeah. So I think in a sense, as some in my GP work, I almost hesitate to say this publicly, but I mean, I think I, walk a tightrope between what I think in my experience and my reading of the literature and everything else, what I think is in the best interest of my patient, and what I think I can get away with without being branded, a bad doctor, quote unquote.
Yes.
Because those guidelines that doctors work to, the things that say, for example, vitamin C is not to be used on the ICU. Well, those guidelines are developed by guideline committees. Those guideline committees invariably involve specialists of a single area, the cardiology guidelines, all that sort of stuff. Yeah. By the time it comes down to general practice, you've got a highly filtered view that's focused on that one disease or one body system. There are usually 4 or 5 drugs for each one of these things. And you start to add that up, you end up in a situation of polypharmacy, which is where we are, people being on really, 5 or more drugs is a problem in my view, because you've got really no idea what the interaction between those things are. But the key thing is that guideline is then constraining that practitioner, because that guideline is then the standard against which that doctor is judged. Yeah. So, if then there's an adverse outcome and the doctor is shown to be not practicing according to the guidelines, they can be disciplined and censured for that. And fundamentally, that means that contract between the doctor and the patient, that involves such old-fashioned notions as, informed consent and shared decision-making, right? That has largely gone out of the window, because the guideline says it. If I don't do it, I'm a bad doctor, therefore I have to do it. Now, I skate close to the edge on that, and I'm probably a much lower prescriber than some of my colleagues, but it's still there, and in the case of, say, IVC or hyperbarics, it's not in the guidelines, so we haven't heard of it, and we've had that locally here from a stroke physician in a meeting with patient and concerned family and friends, who said, well, we've never heard of this. So how could a stroke physician not have heard of hyperbarics?
Yeah, I don't understand.
If it's not available.
You'd have to have your head in the sand, wouldn't you? Like, I know that the state of, the amount of research that's going on in the world and the amount of research that's coming out, that no one doctor can be across everything. That's just absolutely impossible. Nobody can. And we have to specialize and stuff. But, the specialties, even like you separate the cardio, the heart from the lung guy, or these are interrelated systems, and I get the reasoning. Someone who's a specialist in the heart can't possibly be a specialist in what's going on in the brain, but these guys need to talk to each other more, and arrogance needs to be put aside, that you don't know everything. Like I've come across arrogance, like just a couple of weeks ago when I was in the hospital, mum's got a GI bleed. She's nearly died from blood loss twice. The level of blood in her body was horrifically low. The bleeding stopped on its own accord. They sent her home again, and without any diagnostic. And I'm doing the research, and I'm seeing that MRI, and I'm talking to my doctor friends outside of the hospital, and they're saying, yes, MRI is a good diagnostic tool for such bleed. I go to them, and the surgeon, I came prepared with the research, like a court case. Every time I go to the hospital, I prepare like I'm a lawyer going to fight a battle in court, because that's exactly what you're doing. He as soon as I got half a sentence out of my mouth, he said to his junior staff, take care of it, and just walked off to the next one. And I was just like, and she was sent home in an extremely fragile state, knowing that if she had another bleed, she wasn't going to make the hospital, and I've gone then since that point, gone to my doctors outside and said, what the hell can I put in to make sure that she doesn't bleed now? And we've gone hard out with things like peptides and BPC 157 and glutamine, and we've gone, all the natural things, the microbiome stuff. It's all we got, right? It's all I've got. And is that enough? Touch wood, she's doing okay again. She's bounced back again, and her blood's back up at sort of, reasonable levels, still slightly anemic, but reasonable levels again, so that she may survive another bleed. But this is the frustration, right? They don't want to spend the $1,300, whatever it costs for an MRI for an 81-year-old who's got all these comorbidities. And so they'll just tell you that it's not a diagnostic tool.
Yeah. And you know, fundamentally, they don't want to be challenged in any way. You know,
nope, they don't like me.
I'm sure they don't. But that attitude, take care of it. I mean, that's profoundly shocking.
Yeah, it is. I
just
and my brother was opposite me, and he thought, "Oh God, here we go." You know. but in those circumstances, they also have you by the balls.
Yeah.
Because if you're rude to them, then you're really in trouble. Because then they really shut down all of the support that you can possibly get. You know, and that is this precarious position that the loved ones are in when they're fighting for their family member. And so by sharing those stories, and these have unfortunately been over and over and over again stories, so goodness knows, and I hear stories back because I tell these stories, so people come and tell me their stories, so I hear this over and over and over again. I share these stories so that the person who is in that situation knows that they're going to have to fight for resources, that they're going to have to fight for their loved one, that it's not going to be automatic, and that you better push back, and that you better go and do your own research as best you possibly can. And yes, you'll be rubbish, and yes, you'll be ridiculed as, oh, you're coming with Dr. Google, are you? Well, I can tell you that all of these stuff is that you have access to, I have access to as well. There may be a few hidden papers that I don't have access to, but I can get them through my doctor colleagues and friends that I have. Don't treat me like an idiot just because I didn't go to med school.
I think these days that's probably an advantage, to be honest, not having gone to med school. Yeah,
it is an advantage because you're not like this with your hand up the back. And I know really good doctors who, like yourself, are going, this is so frustrating. I know what I should be telling this person. I can't say it. I can't do it. And this is where we need to change this model. And I think this is where people like me sit, also walking fine lines sometimes. But we have to be brave because we're standing up for the people we care about and our clients and our loved ones to get the best that there is available. You know, and Hyperbarics is like, well, this one's a no-brainer for most people. There are a few contraindications. Yeah. And on that note, we did one yesterday. We had a client that was under your consult with you to make sure that they were okay to come in. Because with Hyperbaric, what are some of the contraindications where you'd say, oh, we have to have a look at a bit closer here?
Yeah, there are a few. There are relatively few absolute contraindications. A pneumothorax, partially collapsed lung is definitely one, because that's going to get significantly worse and possibly tension, and you don't always survive that. So that's a bad thing. But also you would look quite carefully at people with chronic chest disease or previous chest surgery in that regard, right? So if somebody's got really awful emphysema, so that they've got these great big dilated sacs called bullae in the lungs, that could burst and cause a pneumothorax. So that would be a big thing. You've then got certain sorts of chemotherapy that if you're within a few days of them, there can be effects. There's a couple, we won't bother about going through what they are, but there's a couple there that we just have to be a little bit careful of. And then you're talking about things like sinus issues, middle ear issues, things that are going to be a problem under pressure. Diabetes, you have to be a little bit careful with, just because blood sugars can drop a bit in the chamber. So essentially it's just a case of checking blood sugars beforehand and making sure that it's not lower than a reasonable level. So you've got a bit of wiggle room there for it to drop. But those sorts of things, we've got a list. I mean, I don't like people going in after recent dental treatment, because sometimes the pressure can actually cause a tooth fracture if there's a cavity there or some defect. So we screen everybody. We got a standardized tool that we use to do that, to look specifically for all the contraindications and also just to take a general view of somebody's health. And then I speak, so certainly in terms of what we do here in Wellington, I talk to all the patients initially, make sure that there's nothing there in the background that we haven't picked up, brief them thoroughly on how to manage their ears in the chamber, and then I will go in for the first session, because we have the luxury of that with a multi-place chamber. I can go and sit in an adjacent seat and just keep an eye on them through that first treatment and make sure that they've equalized their ears properly and they're pain-free and enjoying it. So as you say, overall very safe. Few absolute contraindications, some relative ones that you just have to be a little bit cautious about. Yeah, touch wood, we haven't had any major issues up to this point at all, and we haven't perforated an eardrum, which is excellent.
yeah, and you know, these things we need to know about. And then there's the thing, you know, people might be hearing this and go, right, I'm going to come and I've got, I don't know, major concussions that I've had in the past or something like that, or stroke or whatever. Do I just need to come once? Unfortunately, the answer is also no.
if only, yeah. I mean,
yeah.
and this is and this is the, I mean, this is the other barrier to treatment, especially where the public healthcare system don't come to the party. You know, this is relatively expensive, and it's extremely time consuming. So, you know, if you've got a historic traumatic brain injury, something really even moderately complex, then you're going to be needing, you know, 40 to 60 sessions of this, and that is far better delivered in, you know, consecutive weekdays, you know, 5 days on, couple of days off at the weekend, consistently for several weeks. Where people do that, they have much better results, we find.
That's what I found.
And the ability to dedicate that much time on a daily basis is a luxury for some, you know, that they just can't afford.
And I think, you know, like that, you know, on that note, you know, it depends on the severity of the condition too. So some people don't need a full 40, but someone like mum would, you know, like mum's been doing it. Or we do have the occasional break where she has a month off here and there, and that's part of the protocol too. That, you know, but basically, for the 8 years, she's had hundreds and hundreds of hyperbaric treatments. I've lost count when I got up to 400 or something. So it is a, you know, something that can be ongoing, you know, and supportive. But if you've just, you know, like my brother just had a hip surgery, hip replacement, and I was trying to just get him to do 3 treatments before, 3 treatments afterwards.
Absolutely.
We've managed the after. Didn't come before, but just those 3 would have been beneficial going into surgery, and, you know, 2 or 3 afterwards just to speed that recovery. So it doesn't always have to be a block of 40.
Yeah, 100%. Yeah. So you've got something. So post surgery would be 1, and, you know, there is benefit even to just 1 post surgery for wound healing. One of the first patients I treated was my wife, because she very unexpectedly developed acute appendicitis last year on Mother's Day. Which fortunately I picked up early. We managed to get her in. The surgeons took 12 hours to scan and pontificate, and eventually go, oh yes, it is. The dumb GP was right, with his hands and his eyes and his ears. But you know, she was actually then one of the first patients, quote unquote, that I took through our new chamber that had recently arrived from Europe, and 3 sessions afterwards, I mean, the wound healing was absolutely primo, and it was laparoscopic. So I mean, we're not talking great big wounds here, but it was absolutely superb. And I think, you know, the other thing around that would be, you know, we talked about adjunctive cancer therapy, radiotherapy. You know, if people are undergoing radiotherapy, you know, the trouble with that is the huge amount of friendly fire. You know, the collateral damage that you get from all the surrounding tissues. You think about really hard to treat conditions like radiation cystitis. If you're having irradiation to your prostate gland, for example, having hyperbarics, you know, ideally concurrently, but, you know, alternatively straight afterwards is really going to minimize that, because we're healing wounds, we're healing burns, whether they're on the inside or the outside, and it doesn't necessarily need that many to achieve that effect and to at least limit the damage. There are some forms of radiotherapy, I think particularly head and neck, that's just absolute hell on earth. I mean, I think back to the worst medical job I ever did in my life, which was an oncology rotation back in my native Sheffield, and it was, you know, heinously understaffed and just really such a traumatic experience that about 6 weeks into the job, I developed Pomfilix, sort of a particular sort of stress related eczema. The consultants say, "What the hell's the matter with your hands, boy?" I'm like, "Oh, I don't know, boss, but
I'm stressed
this job." But the level of the mucositis that people get, mouth, where they just can't eat from this stuff, it is your worst nightmare. I would love to see radiotherapy patients getting hyperbarics as absolute standard. It really is a no-brainer.
And before and after, in that case, because lots of people have to go for radiation and radiotherapy, and I have a friend who's just producing a movie, Maggie Bradley, and she is making a movie called Cancer Evolution, and it's all about the metabolic approach to cancer. And she had metastatic cancer, stage 4, like tumors everywhere. I think there was something like 80 tumors. Like, she's got the MRIs of the tumors, and it's just insane. And she wasn't meant to live, and obviously, and she did the whole metabolic approach and has healed herself. And now she's years down the track, and she's making this movie about the metabolic approach, right? Awesome. And she said the only thing that I've got damage from was the radiation. And if she'd known now, she could have done other things to prevent some of that damage that she has ongoing is a problem. So, this is something that you really, really want to think about if you are stuck in that horrible position of having to have that. There are reasons to have it for certain things and certain times. If you can do something to mitigate the suffering, this is what frustrates me, because I have a very preventative mindset, just because I've experienced such horrific things in my life with my family and myself even. It's like, hell no, I don't want to go there again, just to save me or save my family. What am I missing? So I'm constantly studying and researching to be in that preventative space, so I hopefully can catch things early and stop horrible things happening to us. And you can't obviously take all the risk out of the universe, because something's going to come and hit you sideways that you didn't think about that. There's always something that you're sure, shit, I wish I'd studied that now. However, I can mitigate a lot of the risk, and I can repair after the damage has been done. And, if you can put people into the brain of mum after her aneurysm for a few days and then bring them back out as to their normal self, they would be not eating the rubbish, they would not be drinking the massive amounts of alcohol, they would be losing the weight, they'd be going to the gym, because they would know how horrific that journey was. And when you can transfer that, this is what it feels like. I mean, even with my brother the other day, he wouldn't come prior to the surgery. After the surgery, it was like, oh, when can I get in? Because it was worse than you thought, because you've forgotten how bad it is and how bad the pain is. And we as humans tend to do that. I know with ultra marathons, you get to you in the middle of the ultra marathon, you're going like, never again am I going to experience this pain. This is horrific. Why the hell am I doing it? And then you get across the finish line and you're never again. And then within 24 hours, because of the excitement, you finished, you got the medal, and you've forgotten the pain. Well, you've delivered the baby, you've got the baby, you've forgotten how bad the birth was, right? And then you're off planning the next one, the next race or whatever. That's what we do as humans. Hey?
I'll take your word for it on that.
You forget, though, the pain and the suffering that you went through very, very quickly. Whereas I try to no, let's be preventative. And I try to get this across to my healthy clients who come is, let's do some baseline testing while you're healthy. Yes, it's some money in investment now, but if you do that baseline testing, then when things start to go south, we've got, and I'd love to go and get, MRIs and things like that. So we have a complete, and clearly scans and things like that, have a complete data set of what is you healthy. And then when things start to go pear-shaped, then we do another and go, oh, that, your hormones have dropped off a cliff, or you've got a spinal, scoliosis that's now starting to develop in the last 2 years. And because then we can, make a comparison and you can actually see, but that's not always doable. because it's
No,
always
that's right.
resource
That's right.
driven.
And sometimes as well. I mean, screening and going on fishing expeditions for problems before they manifest just increases the amount of time that that you have a diagnosis. Without being able to change the outcome. But I guess it comes down to what your paradigm of preventative healthcare is, right? Because general practice has an idea of what that looks like, and I got to say, it's fundamentally unsatisfying medicine to do, really. The micromanagement of risk factors, and that's really what it's all about. If everybody has a cardiovascular risk assessment that's based on lipid profile and blood pressure and family history and a few other things, blood sugars, that sort of thing. It spits out a percentage risk that may or may not be accurate, and then the algorithm says, this person needs a statin. Consider this, consider that, consider the other, and even in my 20-year career, I've seen the pendulum swing so many times. Aspirin's a good thing in primary prevention, it's a bad thing in primary prevention, or maybe it's all right for some people. And when you've got the patient in front of you, I tend to go to the online risk calculators where I can show them what the benefit of an intervention is, because the reality is that the majority of the time it's extremely modest. So you look at figures like the number needed to treat. It's a good sort of stats measure. It's the reciprocal of the absolute risk reduction. So it really just tells you how many people need to have this intervention for one person to benefit. You look at things like blood pressure and that sort of thing. It's sort of in the order of 80 to 100, depending on whether you're talking about stroke or heart attacks. Lipid lowering in low risk people is a complete fool's errand, and I think
and a dangerous one, really, because you need cholesterol. This whole argument,
the whole hypothesis, I think, is actually fundamentally wrong and is based on bad premises. That's been rehearsed by lots and lots of people far smarter than me. But I discovered Malcolm Kendrick's work on that very early in my career. I think I was a GP registrar, so I was about to pop out as a specialist generalist at the end of the treadmill, and I'm thinking, holy cow, this is really bad. Like we've based an entire industry on a study that was extremely fraudulent, and also policy that came out of the US Department of Agriculture related to our food and our diet. So you've got micromanagement of risk factors, and then you've got what is actually prevention, which starts with nutrition. And you asked me the other day how much nutritional training I'd had at med school, and I had to say, hand on heart, I don't remember any, right?
None
at all. So that's something that I have had to educate myself on post-grad. Did a fairly deep dive on that stuff just over a decade ago. Wow. Discovered the sort of paleo movement. Some of the people you've had on your podcast, so avid consumers of Rob Wolf and people like that, and fixed my own health that way. Got quite overweight, sitting on my fat backside in a GP's chair, advising people on nutrition that wasn't working for me. So then the power of that and the broken nature of the medical paradigm was then very, very obvious to me. And movement. You've got one expression of that. That's awesome. There are multiple expressions, and just getting patients to walk, getting people to walk every day. You do 20 minutes of walking a day. That's achievable for most people. Even in New Zealand, with its frequently shocking weather, you can just put on a better coat and go and do it. So that's one aspect, and then you get into like really basic stuff that for some reason is the preserve of functional medicine, because conventional medicine doesn't want to touch it. But goodness me, vitamin D.
Yeah.
How
during
many
the pandemic,
how many studies do we need? Yeah, exactly. And there was another fantastic study that came out quite recently, and out of Canada, I think, and it was a 10-year prospective study of people, so two groups, vitamin D, no vitamin D, in a place that obviously gets even less sun than we do. And they showed that the risk of Alzheimer's was dramatically reduced, and you could see those the two lines start to diverge after 12 months. I mean, it didn't take very long for that to be the case. We cannot in New Zealand, we cannot do publicly funded vitamin D tests. The patients have to pay for it, right?
Yep.
And then
I ask every doctor to do everyone for my clients, and some doctors have done it, but I mostly send them to my tests, which is an online thing where you can self-order, pay the $25, get that tested.
Yeah, and I mean, we obviously we can request it, but they have to go and pay for it, which is okay. But why is that the case for vitamin D? Why is it the case that the only formulation that we've got is the massive dose, supposedly once a month?
What is with that?
Yeah, and
it's always confused me. Like fat soluble vitamin, and like I'm a fan of 5,000 to 10,000 IU, so quite high dosages per day, especially like I do genetic testing, and if I have my client and they've done genetic testing, I might see there's 3 genes involved or 3 main ones involved with vitamin D, receptors, the transport and activation genes. And if they've got poor genetics, we definitely want to know what your vitamin Ds are. And then usually it's a 5,000 to 10,000 IU dose with K2, by the way, D3 plus K2.
Yeah.
And it's just like a no-brainer. There's this 700, I want to say, processes in the body that vitamin D is implicated in.
That we know about,
yeah, bone health, adrenal, the adrenal system, HPA axis. There's just so many. The Alzheimer's was a new one on me. I didn't know that one.
Yep.
And this is so cheap, so easy to fix. If in a time of COVID, why were we not handing them out on every street corner?
Yep. Some countries did.
Yeah,
but not us. And therein lies the problem. It's cheap. So yeah, I personally take 5,000 units in the summer months, between daylight savings times, and 10,000 in the winter, and that's the result of having done some levels back in the UK, and seeing that 5,000 just wasn't enough to optimize my levels. So where you can go online at the moment and you can buy that, we have to import it in New Zealand. I guess your US based and other viewers and listeners won't necessarily know this, but the maximum that you can buy in New Zealand, I think, is a 1,000 IU tablet, which is very highly subtherapeutic. You may, if that's all you're taking every day, okay, but you may as well not bother. Or you're taking multiple, and it then does become expensive. Whereas
that's why I imported it out of the States.
Yep, me too. Yep. And that's so basic, And then vitamin C and zinc and some of these other basic things. I mean, you imagine a public healthcare system that prioritizes these things, not statinating the population and constantly shifting the thresholds lower and lower and earlier in life, where you start to look at these things. I mean, that's how you improve health.
Yeah, on the cholesterol front, why is this an overly simplistic view, and why can't we get LP little a and PLAC and apolipoprotein A and B? We can actually now online order those two, actually, particularly through my tests, which great, go and do that, people. But explain a little bit the whole cholesterol panel. I'm putting you on the spot here, but why is that a very simplistic overview? When we get the cholesterol, we get the LDL, the HDL, the chol HDL ratio, and that's it. Why is that not enough info?
Yeah. They measure the stuff that's easy to measure, and then prescribe drugs that target what you can measure. And of course, we know that just because something can be measured, it doesn't necessarily mean it's important. And the converse is true. So the standard cholesterol panel, I'm saying cholesterol in inverted commas because we know that it's not as simple as that. In this country, at least, includes the total cholesterol, which is people look at it and they go, "Oh, your total cholesterol's high," and I go, "So what? Meaningless."
Yeah, it's actually good.
If you're a woman, particularly, it's way better. You've then got LDL, which is a calculated value, and LDL is made up of different subfractions of different sizes. Some may be implicated in heart disease, most are not. And then you've got the only two that I actually look at. To be honest, I ignore total and LDL, and I look at HDL and triglycerides. Essentially, you can infer quite a lot about somebody's diet just by looking at those two measures. The triglycerides are going to be raised in a situation of standard Western diet, lots of refined carbohydrates. You see very high levels in diabetics, and they get brought in to see me to go, oh, their triglycerides are high. Do you want to give them a drug? And I go, no, they need to improve their glycemic control.
Yes.
Ideally through diets, not through the medications, if we can get away with it. So that infers something about the carbohydrate levels, and then the HDL is often a proxy for how much natural whole food fats people are eating. So somebody on a paleo primal, low carb, high protein, LCHF, however you want to term it. Got to keep colleagues like Grant Schofield happy by mentioning LCHF, which I seem to remember. He rebranded as low carb healthy fat, which I think is much better. All of those approaches, they're going to raise your HDL in most cases, and they're going to lower your triglycerides. And if you've got a ratio of high HDL and low triglycerides,
low triglycerides being under 1.3 or under 1?
Well, I mean, ideally under 1. I think the last time mine were measured. In fact, this is how much store I set around doing lots of blood tests. So the last set of blood tests I had done on myself were just prior to my second immigration medical, when I decided to stay in the country, and back then they were still doing fasting lipids, which is a nonsense for everything apart from triglycerides.
All right.
And I ate 4 eggs cooked in butter before going to have my cholesterol test done. My HDL was 2 in our units, which is different in America. Yeah. My trigs were 0.5.
Wow.
So you've got a 4-to-1 ratio, so you can easily get it under 1. With a low carb diet. That's the only thing worth looking at. Yep, that there are much more complex tests that can be done that we can't do, and that's not really an area of my practice in any detail at the moment. But certainly this fixation on total cholesterol and LDL.
Yeah, like my total cholesterol came back the other day at a blood test, and I do like to do blood tests because I do like to read, like I'm going for optimal, not what the ranges are. Sure. Not that, and that's the way I've been taught by my teachers, is to look for the optimal, and trying to things like albumin. The albumin should be nice and high, and lots of nuance here, but that can help us. But my HDL come back at 3, which I was quite shocked at myself.
Nice. Very good.
That was quite high, but the doctor was concerned about that, and should be closer to 2, they thought. And my trigs were 0.7, I think. Nice. And my LDL was too high, though. It was what was it? But the ratio was okay. But the whole and the total cholesterol was 7. It's very high, right? And I'm not panicking because my HDLs are high, And again, I probably should go and do the other ones, but I'm still learning those ones, the apolipoproteins and all of that.
Well, I mean, you can infer quite readily from that ratio of HDL to trigs that the LDL that you have is likely to be not a problem. It's likely to be the larger, fluffier LDL, without necessarily the need to dig into it. Unless obviously you're particularly interested, so perfectly fine to do that. But again, talking about skating close to the edge, somebody like you would be brought in by the practice nurses who get the blood results back and go, okay, whoever signs them off says bring them in for a chat about their cholesterol. What we're supposed to do is to have a conversation about low fat diets and statins, and then I have a
high fat diet.
and then I look at that and I go, well, from your diet, looks like you're doing this and this, and they usually, I'm usually right. And I go, excellent, carry on, don't darken our door again. Do not worry about your cholesterol again, and particularly for females. It's very, very clear that that you lot, and yes, I did just assume your gender, you lot run a higher level generally than us, and that is extremely helpful going into the later years.
Exactly why
for general longevity,
and for hormonal. So I want my hormones to be the best they can be. I am on HR2, full disclosure, as well, but bioidentical HRT, by the way. but I want my brain functioning well, and I want my membranes to have the good fats. And so, yeah, I do take the good fats, I do pour my olive oils and a bit of butter and, things like that, the evil butter, it's not, the carbs. We generally have too much carbs, I think, and simple carbs in our diet. And God, I love them as well. It's bloody hard. That sourdough that your wife made the other day, beautiful.
It's pretty special. Yeah, I have to limit that. Yeah. But you're right. I mean, yeah, certainly acellular refined carbohydrates, real issue. Plant carbohydrates, potato kumara, something that we've got here, like a sort of sweet potato, is absolutely delicious. Really, really fantastic, especially post exercise. To refill your muscle glycogen, but that's a particular situation, and the timing of carbs, matters.
The timing of carbs, the circadian rhythms of things. We're much more insulin sensitive around lunchtime, and then there's a genetic component, which there's a huge genetic component to this. So you want to know what time of the day and how often. That's what we can help with genetic testing. But yeah, in other words, the standard guidelines that come out, the food pyramid, and Grant Schofield, he's been on the show too, and he's just like, blowing all that stuff apart, and it's all upside down. We shouldn't be having a ton of grains. We shouldn't, we definitely don't. We should all be trying to avoid gluten as much as possible without being anal about it, but we want to be, don't follow the food pyramid, you will get sick. And don't follow the RDA on the vitamins and stuff, because it probably won't be enough. What is it like vitamins? I've interviewed a ton of vitamin C researchers, and they're just like trying to get the vitamin C RDA put up to the, from, what is it, 50 milligrams or something to 100, when they know that actually we need a shit ton more than that. Absolutely. For optimal health. But they're not even trying to go there because, if you can't get it in one, serving of kiwi fruit a day, then it's too much to be putting on the RDA because it's unrealistic. No, it is what it is. Like, we need to be optimizing, and then this is why I'm so grateful to, have you as a friend now, to have doctors that are willing to have these brave conversations. And I think, without getting too political, we need brave conversations. We need open conversations, and we need to have less censorship, more open discussion, intellectual debate. Where did all that go? It just seems to have disappeared in the last few years, where we've got this dogmatic, overreaching
100%. Yeah,
system.
That's a whole other conversation. But I mean, to give you an idea, you're returning to Hyperbarics. We can't take out Google adverts. Okay, so we can't.
Really, I haven't even tried to do that yet for Hyperbaric.
So this is the extent of this unholy alliance of big tech and the medical industrial complex, that because this is a quote unquote unproven therapy, they won't let us advertise.
Wow.
And we know darn well how much search results are manipulated, and things are down rated, so that they're hard to find. And it's been obviously the most egregious during the last 3 years, but it is continuing to occur, and it affects all of us who have approaches that are not considered by somebody somewhere to be mainstream and evidence-based. And who is that exactly? And
who is that is standing judgment? Yeah, exactly. And I mean, I've seen it. I've spent 10 years building a brand. I've spent 10 years building a audience. A couple of the people that I had on the show who weren't of the mainstream opinion, shall we say, I had to take a couple of my podcasts down. I was censored immediately, and I don't have the resources, the income to withstand an attack like that. I'm not Joe Rogan. So I had to take them down, and that's me, little fish, This is happening all around the place. Censorship is a very big problem. We need to have open, discussions, and that's, we're not inciting anything. We're not doing anything
Correct.
bad. We're not saying, we're just saying, let's have intellectual debates on this stuff.
This is the thing. It's, you know, the marketplace of ideas, right? The free exchange of ideas, and may the best one win. You know, if you don't like what I'm saying, refute it, give me a better argument, and I'll listen to it. You know, it's so fundamentally unscientific that quite frankly it's a bit dystopian. I mean, I think I worry about really the totality of the medical evidence that I am resting my practice on in a conventional sense, right? Because so much of it is likely false. You know, one of the most cited papers ever is John Ionides' paper from 2005. It's from the year I graduated, and I think I read it that year, and it probably had a somewhat disproportional effect on my practice. But you know, that paper was entitled "Why Most Published Research is False."
Wow.
You know, and if we can't challenge, if there is an orthodoxy, a correct, a right opinion that is staunchly defended, that cannot be debated, we're in trouble. Actually, we're in massive trouble, because we are essentially then controlled in relation to our health and well-being. There are some opinions that you can't have. There may well be some approaches that you can't do. You know, we're facing down a very significant act of parliament that looks like it's going to go through in New Zealand that will substantially,
it terrifies me.
Yep, therapeutic products bill. It's absolutely horrific. It's going to reclassify natural health as medicines under the same regulatory framework, and we're going to end up with our choice being fundamentally restricted in that area.
Like down to this point where you won't be able to get vitamin C, or you won't be able to do your natural herbs in your garden, or you won't be able to take any, you know, and this will be controlled by who? Pharmaceutical companies, you know, or government.
Right. Yep.
You know, like if you look at Maori medicine and traditional medicines, they are going to be gone.
Mm-hmm.
Their entire, you know, this is a horrific this natural therapeutics bill has, and it's slipping under the radar.
It is.
You know, I had the privilege of going to a big natural health conference recently where I was speaking, and they had a representative from the government there who was talking about what they're doing with the natural therapeutics bill. And I tell you, she got completely roasted, because the CEOs of those big companies that were there, you know, and I won't name names or anything, but they were like, you haven't even asked us as an industry what we think. You haven't let us submit anything. We're taking our company, one of them said, we're taking our company that has over 500 employees and we are buggering off. You're not giving us the ability to get the export licenses. You are hindering this. And they were angry. And this is, you know, like, people don't know this is happening because they're really good at just bringing things under the radar and slipping it in the dark of night. And
it's not just New Zealand. There are similar moves in North America. You know, it's
one of my products has been taken off the market in North America, nicotinamide mononucleotide, a really powerful, great anti-aging NAD booster. That's been helping a lot of people around the world. In America, they've taken it, you know, because it's going to drug discovery or something. So that people are not able to get that anymore there. They have to go offshore if they're going to get it. Good for us, because they come offshore. They buy it from us, you know, or other companies. But this is not, you know, this worries me, you know, on so many levels. This worries me. And you always have to look at where is the money, and like, you know, the amount of lobbying in, you know, American politics is, you know, the obvious place to look, where the billions of dollars is, you know, in lobbying government, and who's putting that behind that, in the pharmaceutical companies, you know, the powers that be. It's not about your health. It's not about personally, you know, you making an assessment. And as a doctor, you know, when you've got a person who's sitting there before you, you've got to do public policy. For 1 in 1,000 people, this is going to be a benefit. And for the others, it's probably not. We're going to give it to you. You know, that type of decision making is just like, shouldn't you be looking at that person and all of their data points and making the best assessment for them?
I find the best thing is to give them the figures and say, does that reduction in risk from 15% to 12% excite you? And they go, not really. And I go, cool, me neither.
And the side effect list is.
Yeah, that's right. How about we
Exactly.
don't do that? Cool.
Yeah,
And then
exactly.
you have
How
to
about we change
document
the
it.
diet?
Yeah,
Yeah.
that's right. That's right.
And do a bit more exercise and try to make some other changes somewhere else. Dr. Greg, you've been absolutely amazing. Thank you for sharing so openly and honestly on the show. I really, really do appreciate that. Thank you to you and Mike for setting up Wellington Hyperbarics. And there's Nelson and there's Palmerston Hyperbarics, and now there's one in New Plymouth. That's me. There's a new one coming up in Auckland and Pukekohe. There are others in Auckland as well. My friend Dr. Dean will be, and Miriam will be opening in Pukekohe. They're going to have 2 hard shell chambers. This stuff is coming. And why is it coming? Because it works. So you'll be able to find this near you, hopefully soon, if not now. And ring and contact Greg at Wellington Hyperbarics. Where can people find you, Greg?
So we have the domain hbot.kiwi, hbot.kiwi.
That's pretty easy. hbot.kiwi. We'll put the links down below. Otherwise, reach out and, check this out if it's something that you need to think about. Dr. Greg, thanks so much for your time today. Very super grateful.
Thanks ever so much, Lisa. It's been wonderful.